Perfect. Thank you, Dr. Black. For objectives, today we'll start with looking at the definition, incidence, and then risk factors associated with parastomal hernias in the setting of patients following radical cystectomy and conduit diversion. After that, we'll move into discussing methods to prevent hernias, and then lastly, Dr. Jack Chu will be joining us to talk about the surgical repair of parastomal hernias. Starting just with a brief overview of some of the complications associated with cystectomy. This landmark paper was published in 2009 in European Urology, looking at early morbidity with radical cystectomy. It took 1,142 patients, all of them undergoing radical cystectomy at MSK. All of these surgeries were performed by high-volume urologic oncologists. The data was entered prospectively and then retrospectively reviewed. Just for baseline, some of the patient characteristics: so median age of 68 years, ASA score 3 or 4 in 43% of the patients, and 26 of the patients had an elevated BMI over 30. Some interesting operative characteristics: 63% of these patients had a conduit. The remaining had a continent diversion. Median operative time was 6.5 hours, and actually 2/3 of the patients did require a blood transfusion. The key takeaway number: 64% of patients had a 90-day complication. 67% of those had a complication during the hospital admission. 58% had a complication following discharge within the first 90 days. Looking at all-cause mortality, 2.7% in 90 days. Only 0.9% of that was inpatient mortality. The majority, 68% of these fatalities, were from a cardiopulmonary event. When they looked at high-grade complications using a modified Clavian scoring, 13% of these complications were high-grade. When they looked on multivariate analysis, the predictors of high-grade complications were patient age, operative blood loss, and prior abdominal surgery. Here's a brief summary of some of the complications. They classified 68 different types of complications. Here are some of the common ones as well as the more severe ones. We won't go through all of them, and there's certainly more than I've listed here. The one to highlight is parastomal hernia actually did barely make it on the list. 4 patients in this cohort had a parastomal hernia, and that's actually within 90 days of surgery. So not a significant early complication. If we look at another paper, though, looking into the long-term complications, specifically of Ileal conduits, this is a paper out of Switzerland from 2003. There's a retrospective review of 131 long-term survivors. Here they actually had 382 patients. Only 131 of them were still alive at 5 years following surgery, all from a single center in Bern, Switzerland. The median follow-up of this group, they listed at 98 months. They only were looking for Ileal conduit specific complications, and they did not include any complications that occurred within the first 90 days from surgery. As you can see, their complication rate was very high, and especially as you increase follow-up to those few patients that were living more than 15 years, essentially all of them had a complication related to the conduit. These were the most common complications that they were able to identify. Again, I won't go through all of them, but the majority, they say 78%, occurred within the first 5 years in relation to the stomal complications. Just to highlight the high fistula rate they have here, 5%. That was actually only looking at surgeries before 1986 when they were doing hand-sewn bowel anastomoses with chromic. And then the high rate of renal dysfunction is certainly seen in those long-term survivors. That's why the number on the previous slide of patients lasting more than 15 years had a 94% complication rate. So to highlight in long-term follow-up, parastomal hernia is certainly a common complication. We'll move forward now to talking specifically about parastomal hernias. First, trying to define parastomal hernias is not easy. So there's no standardized definition or diagnostic criteria. In the most general sense, an incisional hernia relating to abdominal wall stoma is a good definition. This is subdivided into two ways to diagnosis, and throughout the literature, it's inconsistent which paper is using a clinical definition versus a radiologic definition. The clinical definition being a palpable defect or a bulge adjacent to abdominal wall stoma. This can be examined while supine or standing with or without a Valsalva. Some of the papers, it's not even actually examined by the surgical team, but actually just patients self-reporting it on questionnaires. So it is very inconsistent. Radiologically, this is imaging showing a prolapsing hernia sac adjacent to an abdominal wall hernia. Most commonly, this is seen on CT, in part just due to the ease of access for patients undergoing CTs following radical cystectomy. Looking more at the radiologic definition, more of the papers recently since Donahue in 2016 published this paper have all been classifying hernias into three types. Type 1 we see on the left being the least severe. This with prolapse of bowel from the Ileal Conduit itself. Type 2 is when there's an abdominal fat or omentum prolapsing through a fascial defect, as we can see in the middle image. And then type 3, the most severe, is when there's bowel prolapsing through the fascial defect that is not bowel from the Ileal Conduit, as seen on the right side. Now, the first question that comes to mind when we look at these two definitions is the radiologic definition using CT actually improving our diagnostic accuracy of clinically significant hernias, or are we simply picking up clinically insignificant findings on imaging? To help answer this, there was a paper published in the Journal of Korean Surgical Society in 2011. It was a retrospective review of 83 patients. Now, these were from the general surgery world undergoing colostomy with a median follow-up of 30 months. The rate of hernias were 24% on clinical diagnosis and 29% on radiologic diagnosis. When they broke up the different types of radiologic hernias, there was certainly high correlation, especially with the more severe types of radiologic hernias. So in every patient with a type 3 radiologic hernia, they were all clinically detectable and they were all symptomatic. Even with the less severe type 1 hernias, the majority of those patients were able to be detected clinically, and the majority of them were also symptomatic. It's worth noting too that, of course, in this study, the radiologists interpreting were completely blinded to the clinical outcomes of the patients. Looking at the incidence of parastomal hernia, again, very high, variable through the literature, all the way from 5 to 65% of patients being reported to have a parastomal hernia after an Ileal conduit. Most of this is, again, due to no diagnostic criteria that's standardly accepted and a very variable length of follow-up. Looking at a paper from Dr. Donahue coming out of MSK, they have 386 patients undergoing radical cystectomy. Median follow-up was 12 months. They had a rate of radiologic parastomal hernia in 35% of patients. Of note, the majority, 96% of these were either type 2 or type 3, so more severe hernias seen on CT. They had a clinical parastomal hernia rate of 24%. Of note, the majority of these patients with a clinical hernia were either type 2 or type 3, looking at the radiologic diagnosis. Also, of the patients with a clinically detectable hernia, 40% were symptomatic, but if you dig a little bit deeper, 57% had no documentation here, so that 40% may be up to 97% depending on documentation.
How do they, I'm assuming MSK does more than 90 cystectomies a year, so how do they choose who they were going to include in this or not? It seems like they're missing probably a bunch of their patients.
Probably only include conduits.
Oh, okay.
Yeah, there's a few studies, one that's coming up out of USC where they have almost 700 patients, but only about 100 with an Ileal conduit. The rest all got incontinent diversions. So that does bring down some of the numbers, definitely. Looking at two other studies, again trying to answer the question of how common are these parastomal hernias. This is a study I was alluding to, so 670 patients undergoing radical cystectomy at USC consecutively. Only 92, though, actually had an Ileal conduit. The rest were continent diversions. And of note, these were actually all loop instead of end conduits. The rate here, radiologically, was 23%, and clinically was 20%. This is slightly longer median follow-up of 34 months, and the median time to diagnosis was 11.5 months from OR to detecting a parastomal hernia. Another paper coming out of Indiana University, again looking at consecutive patients, starting with 516, but only 199 had 12 months of follow-up and were Ileal conduits. Here the parastomal hernia rate was 29%. They did divide this, interestingly, between patients that were detected both on surveillance CTs as well as clinically, 71%. 21% of patients were radiologically, there was evidence of a hernia, but not clinically. And then 9% of patients where there was a clinical suspicion of a parastomal hernia, but no evidence on CT imaging. Good, so moving on to the symptoms associated with a parastomal hernia. A paper looking at this comes out of France in 2011. Of note, this isn't specific to Ileal conduits. This is a mix of stomas, so 782 patients, most of them undergoing colostomy, as well as a few with ileostomy, and 23% of patients with an Ileal conduit urinary diversion. Here the mean follow-up time was 10.7 years, and this was looking at the time between their surgery and a self-reported questionnaire. The parastomal hernia rate here was 26%, with a median time to diagnosis of 18 months. It's interesting that the maximal time to diagnosis is 27 years in this paper, and it's often cited through other literature. But the main limitation being this is all self-reported patient questionnaires. In this review, 76% of patients with a hernia were symptomatic. Pain is the most common, and then there's a mix of difficulty applying their appliances, urinary leakage, skin breakdown, etc. Looking at the previous study out of Indiana University, looking at the rate of patients with a parastomal hernia who require surgical intervention, it is quite significant. In their cohort, 29% or 58% of their 200 patients required surgical intervention. Of these patients, 45% of their patients with a parastomal hernia required surgical intervention. Of these patients, the indication for surgery, the most part was pain. 15% of those were for acute incarceration or strangulation, and 15% were for small bowel obstructions. So those are certainly important numbers to note. 12% of patients had a repair simply because they're undergoing unrelated abdominal surgery. And to highlight, just to clarify the numbers that I mixed up there, the 29% incidence, that's either clinical, radiologic, or both, and 45% of that cohort undergoing surgical repair. Looking at the risk factors for parastomal hernia, again, controversial in the literature. Looking back at the paper from Donahue out of MSK, they had a rate of 35% radiologically or 24% clinically. On multivariate analysis, the risk factors they found to be significant were female, BMI for every 1 unit of BMI increase, the hazard ratio increased by 1.08. And then preoperative albumin, the thought being probably a correlate of nutritional deficiency. A study by Liu that we previously looked at from Indiana University They found morbid obesity, so BMI over 40 was significant. Obesity with a BMI of 30 to 40 trended towards significance, but was not quite there. And then prior laparotomy was also significant in their study. Now, both of these studies did look at lots of other factors that are often quoted in their literature. The list here, to briefly read through it, so age, anemia, chronic kidney disease, diabetes, smoking, previous radiation, neoadjuvant chemotherapy, operative blood loss, operative time. All of these have been suggested in different papers. None of those were found to be significant in these two reviews. Moving on to talk about prevention of peristomal hernias. The first topic to discuss would be the fascial defect diameter, the aperture it's often called. So looking at the paper from the Journal of Korean Surgical Society in 2011 that had 83 patients undergoing ankylostommy, they looked at, using a radiologic diagnosis, the mean aperture diameter in patients who were symptomatic, and there was certainly a significant difference between these patients versus patients who were either asymptomatic or had no evidence of a peristomal hernia. Now, when they measured on CT the aperture of their fascial defect, symptomatic patients had a mean of 76 millimeters, and asymptomatic patients, or those without peristomal hernia, had a mean aperture of 49 millimeters. They did also look at this and suggest a high correlation between the severity of the radiologic hernia, type 1, 2, or 3, and the aperture diameter.
That's the aperture time of surgery. That's the aperture time of hernia diagnosis.
Yes, that's correct. Yes. Very important point to clarify. Yes, so all of these numbers, they measured them the first evidence of peristomal hernia, however far out from the OR that was taken. When they actually went through the surgical technique, so most of them were either Hartmann's or APRs, and they did the classic teaching of making the fascial defect 2 finger breadths intraoperatively. One thing to me, these numbers stood out compared to other literature. We'll see that on the next slide. And these numbers are very large. An 81 millimeter aperture is a massive fascial defect. I couldn't find any clarification of why these numbers are so much larger than other studies. It doesn't quite make sense. Maybe their circumference. I don't think those numbers work either. Perhaps just a different measurement technique on CT. Looking at two other studies looking at the size of the fascial defect at time of peristomal hernia diagnoses. In 2013, coming out of the UK, they had a cohort of 43 patients, again with ankylostomies, and a 58% rate of peristomal hernia. They did find a significant difference in the mean aperture between patients with radiologic hernia and those without, 35 millimeters compared to 22. And they did note that all patients with peristomal hernia had an aperture diameter greater than 25 millimeters. That number was agreed upon in the last study by Dr. Seo as well. Looking at a paper by Pilgrim in 2010, this was coming out of Australia. In contrast, this was peristomal hernias clinically diagnosed. So they actually had an ostomy nurse using this sort of caliper tool to try and measure the fascial defect. They had a 33% rate of hernia, and they found that aperture diameter was independently predictive of peristomal hernia with a hazard ratio of 1.1. Also interesting from these studies, they actually looked at this classic teaching of making the fascial defect 2 finger breadths, and if you take an average surgeon, they said the most common glove size being 7.5. 2 finger breadths is actually a 35 millimeter defect. So looking at these numbers, the first study, looking at a 35 versus 22 millimeter aperture, doing 2 finger breadths with the average size hand is sort of immediately predisposing you to the fascial defect size that they see in patients that are at high risk of peristomal hernia.
How well does the clinical measure of the aperture correlate with the radiographic measure of the aperture?
Good question. I wasn't able to answer that simply because all these studies only looked at one or the other. So this top study was purely radiologic, and the second one being purely clinical. I didn't find any that actually compared both. Going to another stage in the ileal conduit formation surgery, looking at fascial fixation. So this is a paper out of MD Anderson in 2014, looking at anterior fascial fixation. Their conclusion in the title being that it does not reduce parastomal hernia repair rate. This was the first study to examine whether placement of fascial sutures influence the risk of parastomal hernia rates. So it was a retrospective review of 496 patients consecutively undergoing cystectomy with ileal conduit at MD Anderson. All the patients were marked preoperatively by a certified ostomy nurse. All surgeries were performed by high-volume fellowship-trained oncologists. There was only 3 surgeons who accounted for all of these surgeries. There's a median follow-up of 16 months. One thing to note, the decision as to whether to do anterior fascial fixation of the stoma, posterior fascial fixation, or no fixation was left to the discretion of the surgeon, and it was an intraoperative decision.
That's what I'm assuming will do, because one of the surgeons doesn't, and the other 2 do.
Oh, was it?
Yeah.
Okay.
Bart Grossman doesn't, and the other 2 guys do.
Interesting. Okay. In the methods, they say it was left to the discretion of the surgeon, but
True.
yes. Okay. Interesting. Very interesting. For what it's worth, they did look at patient and disease characteristics between the different groups who had different types of fixation or no fixation, and they were not significant. What they found is an increased incidence of clinically detected parastomal hernias with anterior fascial fixation, their odds ratio being 2.3. So a 15.3% rate of parastomal hernia in the cohort with anterior fascial fixation, and 7.3% in those without fascial fixation. The group
Because one guy has skinnier fingers.
it certainly may, and I wasn't aware that surgeon discretion was as you described. The group with a posterior fascial fixation was a very small number and was not significant compared to either. Now, trying to make sense of this, does it suggest that anterior fascial fixation actually increases the risk of parastomal hernia? The answer would be no, in that a better way to put it would be the null hypothesis of fixation reducing parastomal hernia rate was rejected. Now, in their paper, they talked about possible explanations for this. I think Dr. Black has suggested a reasonable one. Their thought was maybe placement of these fascial fixation sutures, which are placed superiorly, laterally, and inferiorly, could actually result in lateral displacement of the fascia and leave a medial defect, which is where the parastomal hernia would develop. There's also thought about increased surgical manipulation or increased traction on the fascia could predispose to hernias. Now, their conclusion was that anterior fascial fixation of the ileal conduit does not reduce the risk of parastomal hernias. Surgeons should consider avoiding anterior fascial fixation during ileal conduit creation.
Sorry, I've never thought of these stitches having anything to do with hernia. I always do it to the trunk.
Yes.
Probably unnecessary as well.
Further on in the discussion, they do say that fixation should not be performed for the purpose of reducing peristomal hernias, but consider it for other purposes, and specifically they do mention stoma retraction.
Doesn't it also seem like just trying to figure out whatever the one surgeon's doing is working?
Good. Looking at doing a robotic urinary diversion. So there's a paper recently, March of 2018, in the Journal of Urology, looking at the natural history and predictors of peristomal hernia following robot-assisted radical cystectomy and conduit diversion. This looked at 383 patients all undergoing robotic-assisted cystectomy and conduits out of Buffalo, New York, all by a single surgeon. Now, interesting of note, they accrued data from 2005 to 2016, but they switched midway in 2009 to doing an intracorporeal urinary diversion. The median follow-up was 18 months and median time to diagnosis 13 months. Now, the incidence of radiologically diagnosed peristomal hernia was 20%. However, this varied greatly between each year they broke it up into. So in 2009, when intracorporeal diversion was started, the rate's actually 41%, versus in 2016, the most recent of the data, the rate was 3%. Overall, the symptomatic presentation in 31% of patients. They did note the prevalence increased by year and then plateaued after the first 3 years. And now to try and understand why there's such a variation between 41% and 3%, there were a couple suggestions, both of them probably are reasonable. One is the thought of the improvement in the learning curve with intracorporeal diversion, and the second being a significant lead time bias in that there's much shorter follow-up in the patients from 2016 than other years.
What was their hypothesis as to why you have less parastomal hernia or why those when the fascial defect is identical?
Yes.
Was there a hypothesis as to why is there less anterior pain or?
I didn't gather a hypothesis from this paper. I mean, I've actually never seen an intracorporeal diversion, and looking at it, through the AUA, perhaps there's just less tension and traction on the stoma, and that it's. I guess the one I saw was doing it through a port site and then pulling it out in a very controlled manner. There's less manipulation, but that's really a stretch. I don't have a good answer.
Did they do any fascial fixation with this technique?
As far as I recall, they actually did, which was interesting. I believe all of them had anterior fascial. I don't believe they discussed that in the paper. I'd have to look again, though. Now, they found on multivariate analysis being risk factors for hernia repair were fascial defects over 30 millimeters, postoperative renal dysfunction, and increased operative time. Now, they did something interesting. They compared to Donohue's previous study looking at the risk factors of obesity and females, and neither of those were significant. And then they suggested that perhaps a robotic approach should be favored in those patients, which is, I think, a bit of a stretch. Their final conclusion, I think, is reasonable, being that parastomal hernia is still common after robotic-assisted radical cystectomy. Now looking at prophylactic mesh, so there's been 5 prospective studies looking at mesh placement at the time of index surgery with the purpose specifically of preventing parastomal hernia. These all use, most of them, use partially absorbable mesh using a sublay technique, and these were mostly during end colostomy formation. These are the 5 studies. I put this more just for reference. We'll look at the one study from Janes in 2010, which is probably the most mature series out of those 5. It had 93 patients undergoing end colostomy. 81% of these patients had prophylactic mesh placed at time of surgery. Of the patients who didn't, 9 didn't because of previous surgeries and scarring, and the surgeons were unable to. And the other 9 were omitted at the surgeon's discretion, usually because of a suspected short life expectancy. At their 5-year follow-up, the rate of clinically detectable parastomal hernia was 13% in those with mesh versus 81% of those without. So certainly significant numbers. They weren't able to attribute any complications to the mesh directly. Most of these were, I believe, a combination of 2 materials, so most of them being essentially monochrome on one side and proline on the other.
Can you elaborate what that sublay technique is?
Yes, we'll get into that, and I'm guessing Dr. Chu will talk about it. If not, I'll answer that. Interesting to note here as well, certainly the concern of mesh infections. 1/3 of these patients were actually done in the emergent setting with either purulent or just gross fecal contamination, and still no mesh-related infections. Looking at another study coming out of Sweden, looking at a 10-year consecutive case series of patients undergoing ileal conduits, specifically with prophylactic mesh. They had 114 patients, median follow-up of 32 months. Now, only 58 patients were included in this analysis, mostly because the rest were not alive at 1-year follow-up, or a few patients declined to participate. They had a 14% incidence of parastomal hernia. Now there was no control group, but comparing to other series, it is perhaps an improvement. They also had no complications that they attributed to the mesh directly. I'm looking at the last paper for prophylactic mesh. This is again out of MSK from Dr. Donahue. So what they started doing as of 2013 was offering prophylactic mesh to all patients undergoing radical cystectomy with ileal conduit who they felt were at high risk of parastomal hernia. They defined high risk based on Donahue's previous paper, which found females and those with BMI over 30 were at higher risk of parastomal hernia. For the surgical technique here, as you can see in the photo, they used a 10 by 10 centimeter mesh. This is the same one we were talking about before, so monocrystal on one side, proline on the other side. It's placed in a sublay position, which essentially means it's placed between the rectus muscle and the posterior rectus sheath. The mesh was anchored to the posterior rectus sheath, and the conduit was secured to the anterior fascia, interestingly. Now it's still early. Of their initial 33 patients, they had a median follow-up in this group of 15 months. Their incidence of radiologically diagnosed parastomal hernia was 12% at a cutoff of 1 year. Looking at Donahue's previous paper, the rate would have been 27% without prophylactic mesh. They concluded relative risk reduction of 56%. They also looked at 30 and 90-day complications. They weren't significantly different, and there was no complications specifically from the mesh placement. Perfect. We'll take a pause and switch gears for Dr. Jack Chu, who will talk about some of the technical aspects of repairing parastomal hernias.